Good afternoon, everyone, and we have a wonderful session ahead of us. And I'm Dr. Supratik Bhattacharya, consultant based at Kolkata, and it's my absolute privilege to present in front of you a wonderful, wonderful speaker. If we can have the introduction slide for Dr. Vijay, please. So Dr. Vijay Negalur, he is the consultant physician and endocrinologist, and he's the director of Renuka Hospital of Advanced Diabetic Care at Dombivli, and since last 35 years. He's also been the director of Negalur's Diabetes Specialty Center at Thane. He's the consultant diabetologist at Jupiter Hospital, Thane. He presently is the fellow of Indian College of Physicians, president of Negalur's Academy of Diabetes Research. He's a teaching faculty in diabetology, teaching faculty at Public Health Foundation of India, founder member for Association of Diabetes Educators for India. He has also held positions like honorary assistant, associate professor of medicine, RGMC Thane, and honorary physician and diabetologist at CSM Hospital Thane. He's got numerous publications, including publications in Oxford Textbook of Diabetes, Autonomic Neuropathy, publication at RSSDI Textbook of Diabetes regarding vitamin D and diabetes, and publication of Awakening Quarterly Magazine for Diabetes since June 2003 till date. He has also contributed as the President ADCP, Chairman Scientific Committee at RSSDI 2012 held in Mumbai, and he had been the organizing secretary for RSSDI Mahakon 2005. And it's an absolute pleasure and privilege, and we are all waiting to hear from you, sir. So the dice is all yours.
Thank you. Thank you, Supratik, for your kind words of introduction. In fact, very generous introduction. And I thank you once again for giving me this platform to discuss with you about the cardiovascular risk management of diabetes. We focus on the SGLT2 inhibitors. The American Heart Association considers diabetes among one of the 7 controllable risk factors for coronary heart disease or a cerebrovascular disease. In fact, people living with diabetes are 2 times more likely to develop and die from cardiovascular disease, such as heart attack, strokes, and heart failure, than people who do not have diabetes. So that's the impact of diabetes on a cardiovascular disease. And if you see, diabetes affects less than 500 million people globally. And if you see, the prevalence is going to increase by 25% by 2030, and it's going to increase by 51% by 2045. If we look at the overall cardiovascular disease mortality that rates in the diabetic patient, with 1 in 3 males, roughly about 33%, and 2 in 5 males, roughly about 40% of the females will also suffer from diabetes and related to cardiovascular disease. So that is the impact of the cardiovascular disease that you can see in patients of diabetes. If you further dive deep into these aspects of cardiovascular disease due to diabetes, you will see that 2/3 of deaths in people with diabetes are due to cardiovascular disease. 40% are because of ischemic heart disease, 15% are other forms of heart disease, principally congestive heart failure, and 10% are stroke. And what is disturbing is the large population in this group is a young population. And furthermore, they could be having a renal impairment as one of the contributing factors, besides the higher burden of glycemia in these patients. So that is going to be a major impact of diabetes, especially on the younger population in this country. Now, this slide by Suzuki tells us about the uncertainty about the long-lasting effects of glucose lowering on the cardiovascular outcomes. We all know, as per the epidemiological data, that we have the hyperglycemia could contribute to cardiovascular disease, though the data of the various trials, the intensive lowering trials on glucose, have not shown much the cardiovascular benefits. So the multiple CV risk factors exist beyond hyperglycemia, because if you look at the ACCORD trial, despite of intensive glycemic control, the mortality increased. That means that a multifactorial approach has been stressed, namely the control of blood pressure, control of obesity, stopping of smoking, alcohol, and taking antiplatelet drugs. All those multi-factor approach has been stressed. And despite that, most of the patients rarely reach therapeutic targets because people are hard to stop smoking. The reduction of weight is also quite difficult in these patients. And therefore, a lot of clinical and the patient factors superimpose on the existing disease. That is because it is difficult to achieve the goals as is expected to achieve in patients who have the additional comorbid conditions besides hyperglycemia. Therefore, we need to have a specific intervention to reduce cardiovascular risk, which will not only control glycemia, but also control the weight, controls the dyslipidemia, controls the hypertension, and so many factors, yet we will not get hypoglycemia. And therefore, that is what is the need of the hour. So we need to have the specific intervention to treat patients of diabetes. Now, this is the picture of the nephron that is seen in front of you. And here is the SGLT2 receptor located proximally in the proximal convoluted tubule and SGLT1 little distally. And SGLT2 is the one which picks up the glucose. It is supposed to be extremely sort of a sensitive receptor to pick the glucose up from the blood and from the urine and takes it back into the blood. And here you can see here, when blocking this SGLT2 receptors, you can see the glucose will spill in the urine, and therefore the stress of putting that glucose back into circulation and also the hypoxia that is created because of overworking of these particular receptors will also be shut off, and there will a lot of energy will be saved off. And what you achieve, you have about 400 kilocalories of deficit diet by excretion of 100 grams of glucose in the urine, and therefore you have a calorie deficit diet, and that offloads the beta cells and therefore can have a good glycemic control that we can expect when you use SGLT2 therapy as a glucose lowering agent. What are the potentials for the modulation of a non-glycemic CV risk factors in SGLT2 inhibitors? Now we know that multiple mechanisms have been explained which can bring about the beneficial cardiorenal benefit, in fact, cardiorenal metabolic benefits in patients of diabetes. One is the development of ketone bodies, and there will be sodium, potassium, hydrogen exchanger, so which is supposed to be very important so far as the exchange of sodium and hydrogen is concerned, therefore preservation of the myocardium, not accumulation of calcium into the cell, and of course glycemic control, improved endothelial dysfunction, prevention of the vascular stiffness, reduction in the plasma volume, natriuresis contributing to blood pressure control, and the increase the glomerular afferent arterial vasoconstriction, therefore reduction of the interglomerular pressure, increased glycosuria, and decreased albuminuria. The age-mediated effects on the age-range signaling pathways, decreased body mass index, decreased adipose tissue, and of course the skin sodium content is also decreased, and hepatic steat is also decreased. So many factors besides glycemic control are contributing for the beneficial effect. These are called as a non-glycemic effect to reduce the CV risk factors in patients of diabetes. This is the snapshot of the various trials which are shown here. The EMPA-REG trial looked at 7,000 patients which had the established cardiovascular disease. The CANVAS trial looked at 10,000 patients with or without established cardiovascular disease or increased cardio risk factor. The DECLARE-TIMI trial had both patients established cardiovascular disease or risk factors for cardiovascular disease in 17,000 odd patients. Credence trial looked at the patients with impaired kidney function and therefore looked at the benefit of using this therapy so far as the kidney functions are concerned as a Credence trial. And DAPA heart failure looked at the patients of reduced ejection fraction, patients of 4,000 with the ejection fraction less than 40 and the NYH class of 2 to 4 and half the patient without diabetes. So that's the entire spectrum of various patients of diabetes or without diabetes, with or without cardiorenal involvement. And what did you see? This is again a very, very busy slide, but it tells you that if you look at the EMPIRIC trial, it's the one which reduced the cardiovascular death significantly. But if you look at the CANVAS trial, it was not significant for the cardiovascular death, though it was very effective in treating heart failure. And the fatal, non-fatal myocardial infarction also reduced significantly, but the all-cause mortality and the cardiovascular death was only prevented by the EMPIRIC trial. The DECLARE TIMI trial had again the cardiovascular death was not significant statistically, but had the beneficial effect so far as the hospitalization for heart failure is concerned. So in other words, whether it's EMPIRIC, whether it's CANVAS trial, or whether it's DECLARE TIMI trial, all of them have shown benefit in terms of reduction for the hospitalization for heart failure, and only cardiovascular death, the beneficial effect was seen in the EMPIRIC trial. And if you look at the CREDENCE trial, which specifically looked in patients who had a end-stage kidney disease or they had a less GFR, and here looked for the new end-stage kidney disease or the doubling of serum creatinine levels or the presence or decrease of the macroalbuminuria in these patients, and it showed quite significant reduction in the heart failure and also reduction in the 3-point MACE, and also reduced the renal endpoints, especially the doubling of serum creatinine levels, and the renal death was significantly prevented in the CREDENCE trial. DAPA heart failure trial, on the other hand, looked at patients of hospitalization for heart failure and the cardiovascular death, and they had the patients who had ejection fraction of less than 40, and here the cardiovascular death was reduced, quite not very significantly, but the hospitalization heart failure was reduced significantly. The outcomes predominantly for the heart failure showed a very significant response both in patients of diabetes and those who did not have diabetes, again suggesting that the beneficial effects of the heart failure and the renal protection, though the CREDENCE trial did not have patients without diabetes, but the DAPA kidney definitely had patients without diabetes. Both these molecules showed a beneficial effect in patients of heart failure and in patients with the impaired kidney function. So therefore now we have the drug which not only controls the glycemia, but also has the cardiorenal beneficial effect in patients of type 2 diabetes or even without patients of type 2 diabetes. This is again a very busy slide which tells us the ACE guideline of the using SGLT inhibitors to manage the established atherosclerotic cardiovascular disease, heart failure, and diabetic kidney disease. Here, the patient is more than 18 years of age with type 2 diabetes with more than one of the following: atherosclerotic cardiovascular disease, heart failure, diabetic kidney disease, or at a high risk of atherosclerotic cardiovascular disease. Is there a patient pregnant or breastfeeding? In that case, you should not give this to a pregnant lady or a breastfeeding lady. If it's not known, then the patient has the EGFR less than 30, then of course you need to have the share the patient's the requirement of this drug, and therefore you advise these patients to give the SGLT inhibitor when the patient said by the shared decision and patient is willing to take this medication, then you continue medication. The patient is not willing, of course, do not start SGLT inhibitors. There can be some constraint, for example, the patient having genitourinary infections. In the elderly frail patients, patient could have syncope, but of course the shared decision is very important before you initiate the treatment with SGLT2 inhibition. And once you initiate SGLT inhibition with a proven atherosclerotic cardiovascular disease, heart failure, or DKD benefits, in which we have canagliflozin, dapagliflozin, and empagliflozin in the appropriate doses. And of course, there's a fixed dose, there's no need to titrate the dose. The other hyperglycemic medicines needs to be adjusted as per the need of the patient's glycemic control. And they monitor the response to therapy, and of course, they consider further therapies for the CV risk reduction, as indicated, for example, the antiplatelet drugs or the anti-lipid drugs, and so on and so forth, for the patient to have additional benefit in the cardiovascular effect. Now, the American Diabetic Association recommendation for the patients of type 2 diabetes with the established atherosclerotic cardiovascular disease or a high-risk atherosclerotic cardiovascular disease in patients with type 2 diabetes and established ASCVD, multiple ASCVD risk factors, or diabetic kidney disease in the SGLT2 inhibitors is recommended to reduce the risk of major adverse CV event and a heart failure for hospitalization. This is the great step taken by the American Diabetic Association to upscale the treatment with the SGLT2 inhibitor in patients who have established atherosclerotic cardiovascular disease with or without heart failure, and among the patient type 2 diabetes who have established atherosclerotic cardiovascular disease or established kidney disease. You can either select the SGLT2 or the GLP receptor agonist with the demonstrated cardiovascular disease benefit is recommended as a part of the glucose lowering regimen in these patients. So the key messages before I close my talk: given the multifaceted pathogenesis of atherosclerosis in the type 2 diabetes, it is likely that the intervention to mitigate this risk must address the cardiovascular risk factors. SGLT2 inhibitors are a novel class of anti-hyperglycemic medication that increase the glucose excretion, thus improving the glycemic control independent of insulin. So it's not using the insulin axis, it's independent of insulin. The cardiovascular benefits manifest rapidly and are unlikely to be related to the improvement in the glycemic control because you get the benefit in number of days. Okay, so therefore it's unlikely because of glycemic control. Evidence from the cardiovascular outcome trials support the use of SGLT2 inhibitors in patients with type 2 diabetes with history of cardiovascular disease, and a paradigm shift should be implemented to focus clinicians' attention not only on the metabolic control but also on the long-term cardiovascular benefits even at the early stages. So with that, I conclude my talk. Thank you very much for the patient listening. It's over to
your valuable time. I'm sure all of us will go back with great insights on the subject of using a SGLT2 inhibitor. This scientific program was made possible in partnership with Koye Equila, and also do watch out this space for more such enlightening and engaging videos. So thank you once again, Dr. Negalur. Thank you.
Thank you very much. Thank you.